I'm going to introduce Dr. Arvind Hoskoppal. He is the Director of Adult Congenital Heart Program here at Children's Hospital, an Associate Professor of Pediatrics. He is going to be talking about complex transposition and the ACHG perspectives.
Thanks for the introduction, Yvonne, and thank you to the course directors for this opportunity, Laura and Victor. And I should probably name this talk, treat them, then what? You know, this is not glamorous, this is not the ICU, this is not the OR, but remember, patients spend 99% of their time outside of the hospital, and that's where my boring subspecialty comes in. And so what is complex transposition? We've been talking about that. In my head, anything that is not simple is complex transposition, but you could argue that there's no such thing as anything simple about a transposition. But for the purposes of this talk, we'll say transposition with VSD and LVOT obstruction is considered complex. What do we do for this? What is the buffet of procedures available? There are tons. The Rastelli and Nikaido, of course, and sending mustard with VSD closure, that is still a possibility. And a REV procedure, ROS, which Kernow rotation of the arterial trunk complex, and everybody and their neighbor have come up with the modifications with that, and that is beyond the scope of this discussion. So for purposes of today, we'll focus on Rastelli and Nikaido, and I'll try to draw comparisons between these, and I'll let you guys judge which is a better procedure. So from a historic perspective, this is important. I'll come to it in a second. Rastelli was first conceived by the namesake in 1967. Okay, and then first successful surgery reported in the late 60s. The basic principle involves closing the VSD to the aorta and putting a conduit between the RV2 PA bifurcation. Why is the historic perspective important? When we are taking care of patients, when patients come to you and it's like, how do you think I'll do in my 60s and 70s? The correct answer is we just don't know. Because the oldest patients, even if they were done as a late repair, perhaps in their 50s. And of course, there's a lag between getting the data and reporting it in literature and making it to the guidelines. So we are still learning as we go about this procedure. So what about the long-term considerations? When we're thinking about it, we think about survival, of course. And this is a unique operation where you can get biventricular outflow tract obstruction, so or problems with biventricular outflow tract obstruction or regurgitation. And less importantly, it's a VSD patch leak or dehiscence and scar-based VT, which is common across most congenital heart disease. So when we look at survival data, there is excellent postoperative survival, at least in the current age. The early mortality is nearing zero. And this paper written by Kreutzer's group, published in early 2000s, reported an era effect where there was early mortality of up to 11% in the 80s. And as they move forward in the last 7 years of their data gathering, it was zero mortality. So definitely there is an era effect. And when we look at long-term survival, it is 80 to 90% long-term survival. And the paper by Cleveland et al. And reported 92, 72, and 48% at 10, 20, and 30 years. But this is an extremely heterogeneous population. So the survival can be based on the complexity of these defects. So what about reoperations? Reoperations on the right ventricular outflow tract. If you look at the ACHG guidelines, they refer you back to the other RV2PA conduit conditions. So the same guidelines which apply to your TED type or double outlets, they refer you back to that. And it's the same moderate or greater PRPS with symptoms, arrhythmia, RV dysfunction, and dilatation. So when you look at RV dilatation and you're looking at numbers, my advice is don't hang your hat on that, because remember when you're doing the Rastelli, a significant portion of the RV volume could be taken up by the baffle. So what is a normal RV volume for someone else it may not be normal with this, so take it with a grain of salt. And freedom from reintervention is actually low on the RVOT, like 56% and 21% at 5 and 15 years. So at about 15 years, majority of these patients had some kind of RVOT reintervention. And with the advent of the transcatheter pulmonary valve replacements, and the data is still evolving, and for what is reported out there, the outcomes are similar to a surgical versus a transcatheter valve as far as longevity is concerned. How about reoperations on the left ventricular outflow tract? The obstruction could be quite complex here, and it could be at the level of the VSD or beneath the valve at the level of the conal septum. But it may also result from a restrictive VSD or a muscular hypertrophy in that subvalvular area. And some of the strategies for prevention of this LVOT obstruction quoted in the literature is later age of repair, if possible, and enlargement of even a minimally restrictive VSD, but this is not a perfect strategy, of course. So again, for what do the guidelines state about the LVOT obstruction? They refer you back to the sub-AS section of the guidelines, and we know that it is a completely different pathology and anatomy, but this is what we got, a peak gradient of about 50 millimeters with symptoms and LV dysfunction leads to BICU and LVOT reintervention. And in the same series by the Kreutzer group, freedom from LVOT reintervention was 84 to 93% at 15 and 20 years. Not as common, but it is still not as common as the RVOT obstruction, but it is still reported. And Adam was showing a bunch of, he's sitting here with his 3D models and multimodality imaging and 3D printing especially, so that surgeons can take a look at it and look at the mechanism of the LVOT obstruction. It helps a lot in preoperative planning. So what about the other procedure we're talking about, the Nikaido procedure? You can see in the cartoon on the left over there. This was first introduced by Bex in 1980. It's a fairly new procedure and put into practice in 1984. And the basic principle involves translocation of the aorta and biventricular outflow tract reconstruction. And this avoids the creation of a long, tortuous interventricular tunnel for baffling the left ventricular blood into the aorta. And again, important to know when this was introduced, that brings us the oldest patient in the 30s. What is reported in the literature are even younger because there is a lag, as we talked about. So when we look at long-term considerations for Nikaido, this is interesting. It's not mentioned in the 2018 guidelines at all. If you search the entire 170-page document, it is not even mentioned. So this procedure doesn't exist as far as guidelines are concerned, and hence we need to individualize approach, but we still think about survival, reoperation, and those are the two main things we think about. And as far as survival is concerned, there's excellent post-op survival, and at experienced centers, that is the key, and the immediate survival is, or immediate mortality is nearing zero. And there's a variety of papers out there, all small studies. I'll come to those in a little bit. 85 to 90% 10-year survival, and this is a very heterogeneous anatomy and with surgical variations and modifications. It's difficult to draw broad conclusions based on what's reported out there. As far as reoperation is concerned, they can get aortic regurgitation, aortic valve surgery, and RV2PA conduit, if used, I would say, though it's not mentioned in the guidelines, we should apply the same principles as other RV2PA conduit situations. And branch PA problems if a Lecomte maneuver is used. But the take-home message is read the op report, because if you ask Victor, what did you do? His op report is, I fixed it. So, but if you read it in detail, I've learned over the years is no two surgeries on this complex transposition are the same. So even if this was done 30 years ago, we dig out the op report so that this guides and this helps us guide the management strategy. Coming towards the end, this is a comparison of all the most of the studies which are out there reporting the data about Nikaido in the top and Rasterly at the bottom. If you look at the number of patients, the largest study for Nikaido was 18 patients, and most of them are in single digits, slightly higher numbers for the Rastelli. And the same thing with follow-up data. We have a longer follow-up because Rastelli has been around for longer, and not a lot of long-term follow-up data for Nikaido. But this is the meat of this discussion is like reoperations, and a ton of reoperations in Rastelli, and one of the goals of doing the Nikaido is avoiding the reoperations. Though there are RVOT reoperations, none on the LVOT, at least in this near-term data, which I think is important to know when we pick candidates for different surgeries. So in summary, Rastelli has been around since the 1960s. It may require reintervention on both the outflow tract, and it is widely used, hence we have more data about it. And I did check this with Dr. Morel about whether this is straightforward or not. For me, it's easy to say, but he did agree that technically Rastelli is more straightforward, and we do have transcatheter options available for RV to PA conduit reintervention. And whereas Nikaido is fairly new since the 1980s, it prevents this LVOT obstruction by creating the straight line connection between the LV and the aorta, and much less reduction in the RV volume, and hence can avoid the potential reinterventions in the future. But a word of caution is this is a fairly new technique with limited data, and it is a technically challenging procedure, and at experienced centers, we do have good outcomes. And that's all I got. Thank you very much.